nuclear medicine, which helps us with things like PET scans, as well as radioactive iodine, et cetera. Then there's your endocrinologist. So this is often who patients see either after surgery sometimes before surgery, and that can vary again depending on where you're at. But the endocrinologist's main role is to help in the risk stratification of initial disease. That's often done in conjunction with the surgeon, cancer surveillance over time, and of course, assessing your thyroid hormone status, and sometimes some of the other endocrine issues that could come up after surgery, like hypoparathyroidism, et cetera. Next are your surgeons. And again, this could look like different things depending on where you're at. It can be an ENT surgeon. It can be an endocrine surgeon. The most important thing is that you're going to a high volume surgeon in terms of thyroid. I always tell patients, if anyone's was going to need to operate on my neck, I want someone who's doing that surgery multiple times a week, not a couple times a year. So making sure, and this can be a little bit harder to find depending on what part of the country it is, sometimes something you do have to travel for, but is very, very important in the care. It can also sometimes involve a thoracic surgeon if disease is further down in the chest, et cetera. Radiation oncology, sometimes this may be recommended in certain thyroid cancer patients' journey, depending on each particular situations. Normally, this is to help control one area of disease that happens to be growing when other areas of disease are stable, or sometimes when an area of disease is becoming symptomatic. And lastly is oncology. This can also look a little different depending on what institution you're at. So there are medical oncologists as well as oncologic endocrinologists, both of which offer systemic therapy, immunotherapy, chemotherapy, depending on what verbiage you'd like to use. They play a role in cancer surveillance as well as actually prescribing and helping coordinate the administration of these medications, and then just with overall cancer care coordination in general. So I wanted to open it up because I think, again, it's important to kind of share experiences. Is there anything in any of your guys' journeys that you realized was really important and then it maybe up front you hadn't really thought of? So I know that's kind of a hard question, but go ahead.
I was saying my initial diagnosis was done by an ENT, so then I had my surgery done by an ENT, but I did end up with hypoparathyroidism after the fact. And a lot of time I get people saying, "Oh, that's because you had your surgery done by an ENT," which I don't think is a proven thing. But your point about asking about the volume, like, in retrospect, I wish I would have asked those questions about how many thyroid surgeries he did on a regular basis.
And as someone who's had the opportunity to train at a lot of places, what I can say is I've seen, the expert thyroid at one institution be ENT and the expert thyroid surgeon in another institution be an endocrine surgeon. They're trained a little differently. ENTs go through an ENT residency. Oftentimes, especially if they're very subspecialized in thyroid, doing an additional oncology fellowship, whereas, and they stick to the neck generally. And then our endocrine surgery colleagues go through a general surgery residency. So they operate from here to here. And going forward, they do an endocrine fellowship. And then they operate in the neck and oftentimes in the adrenal glands as well. What I can say is they can both be excellent. I think it just depends on where you're at. And I think the key question is, are you doing thyroid surgeries often? Makes sense. The more often you do something, the less chance you're going to have complications with it. Yeah, go ahead.
How do you know if you're if you have a good ultrasonographer? I mean, I get mine done at the local hospital, but I have no idea how good they are.
It's a great question. And what I can tell you is it really, really varies. Part of that is speaking with your endocrinologist. Another tidbit is, how do you feel as the patient when they do it? A lot of times patients can tell if they put a probe on you and it goes up and down for just a few seconds and never goes to the lateral sides of your neck, then that's not an adequate ultrasound. And I've definitely seen that at large hospitals where it doesn't go to the sides of the neck. So, and sometimes depending on if whether your endocrinologist is comfortable with thyroid cancer, they may not realize that. So bringing that up from the patient perspective, being like, hey, they did my ultrasound, but they never looked over here. Is that normal? Should I consider going to a different place for my ultrasound? It's another way you can be your own advocate.
How I was found out when I first was, I had a pain radiating down my leg, and I did therapy, I did different things, and finally I had a neurologist. They said, let's go to the, and she's like, she looked at it like, and then she did another test, like going, there's a lump there. I'm gonna sit, and then she sent it to Mayo's, and they're the one that diagnosed, because I live in Bloomington Normal, which is kind of there, but I did do treatment there. And but when people keep on saying you're unique, or oh, look at that glowing, and that, but I mean, like when I had my thyroid taken out, I had an NDT, but he affiliated with Mayo's, but he replanted my parathyroid, so I think he did a good job.
Mhm.
My voice is still okay, and that, but now I've been like 13 years, and you go from place to place, and when you're your own advocate, when you don't come from a small, Bloomington's really not a little bit, but I mean, it's not a big city, and that don't be afraid to say, hey, this is not working right, or the key terms are unique. We're going by the book, because I went to Barnes and had a guy do it, and we did to get rid of my back. We did radio frequency, and that worked well, and but I was an oncologist there, and he's like, we're going by the book. And it's like, with going to thyroid conferences really has helped to kind of see there's other options. There's not just one thing, and like it says what fits you.
Mhm.
And then after she said that, I went to Mayo's, which diagnosed me, and now I'm I'm looking for another team now that's more of a team, because I've been keeping my, when you said primary, my chart, I've been keeping them, say, hey, look what the reports are. And, my endocrinologist from home, and that, hey, look at the things too. And that, like I said, I had a retired one, and then now I have a different one. And at Mayo's, and I'm like going, no, my levels are doubling. And it's like, I need something else now. And I want like a team. So that's why I've been looking at MD Anderson, and where I'm living in Normal, Illinois, and that's so Northwestern, because there was a guy that he's here. So trying to weigh my options, which is the best. And even 13 years out, because it's in the bones, and it's like going, when you had a fracture at one time,
Mhm.
and you went to a regular hospital, like, what, did you have a heart attack? No. And did you know I had spots in your lungs? Listen to things that they say, and then be your advocate and ask questions, and then try to find somebody that best. And like I said, the ThyCa has been very good in that. You just kind of go and get the information, and then just see what's out there. So
I think ThyCa is a great way to share that information. I think you pointed out another quality that I definitely encourage looking for in a medical team is the multidisciplinary approach and communication with that, right? Being at a center where the surgeons talk with the endocrinologists talk with the surgeons, the nuclear medicine, pathology, radiology, because it truly is a team effort. You need everyone communicating in order for it to work well. So there are multiple centers throughout that have multidisciplinary teams. Oftentimes they'll even tell you how often they have their conferences and when they meet. Part of the beauty of us having Zoom is I think it's made it a lot easier. I mean, even aside from the largest cancer institutions, it's made it easier for smaller institutions to be able to all get together, have a radiologist there, have a pathologist there, and everything like that, and talk. Kind of funny, we forget how important just talking is sometimes. Yeah.
What's worked for me, I'm still new, it's only been a year, but what's worked for me is I was referred to a neurologist and immunologist because I was concerned about autoimmune things. And then surprisingly, my OBGYN is, I made sure that all of my doctors are in the same network so they can talk to each other through my chart or if they're seeing each other in the hallways. And surprisingly, my biggest advocate has been my OBGYN. She has referred me to so many different people, licensed dietitian as well, and then a gastroenterologist for
Nice.
me.
So I
So
think
I don't know
it's
if that helps anybody else.
voicing your need and figuring out who can help you get that addressed. That's awesome.
I think the biggest thing I would tell people to look for a medical team is providers that don't get irritated or upset when you ask questions. I was at a cancer center and that happened. She didn't take my concerns seriously.
Mhm.
And when I was asking questions, she literally rolled her eyes and go with your gut. Like that was a bad taste in my mouth and I did not go with her. So don't go with someone who gets irritated that you're asking questions.
I think that's a very good point and a great segue actually to our next topic. But before we get there, anyone else with any other experiences? And again, we're going to have some time to share. Of course. No.
If your diagnosis changes from papillary to PDTC ACT, even a good team may not be prepared to work at the pace that the disease requires.
So again, so that's going from a differentiated thyroid cancer to a much more aggressive pathology, including ATC and poorly differentiated thyroid cancer. And I think that's also, maybe bringing up that the team you thought would be equipped to handle you up front may not be the team that's equipped to handle you after you have the pathology. And I think this is where sometimes you really have to be your own advocate. Being at Anderson, I see how many patients, see that diagnosis of ATC and, call us up. That's all it takes, right? So especially for some of the more rare diagnoses, you may actually know more than your local team in regards to that, okay? So I think as you brought up is when to know to ask for a second opinion or when that may be a good idea, okay? So first, just looking at what is the definition of a second opinion, right? It's when you have another doctor review your records, meet with you, and give you their opinion based on their review of the records, and come up with their treatment plan. Now, sometimes this could result in them agreeing with exactly what your first team said. Sometimes it can lead to a change in diagnosis, as what happened with one of our Zoom attendees that was coming on. Sometimes it can help you find a misdiagnosis, as it did in her case, and then it just really helps ensure that you're getting proper care. So when should you consider doing this? I think this professor from Yale, Dr. Grauer, put it best, is second opinions are good when there's not a perfect answer and you want more input. And this comes up a lot in thyroid cancer, okay? There is a lot of gray area. I love how science is moving and we're finding out new things. I mean, part of why I went back to do, after practicing for a long time actually, to go back and do more training is just because we have so many more options. And I wanted time to just concentrate on learning all of that. It's a lot for people to keep up with. So especially when now that we have new drugs, trials, et cetera, a lot of the times there may not be a particular right answer. Sometimes you may want to speak with someone who will explain more of those options for you and everything like that. Another reason to consider it is you just think something's not right. Like you said, go with your gut. If you're feeling that something's off, et cetera, remembering that you always have choices and options, okay?
I find it hard to get the doc to answer the hard questions like, what does the end of life look like for me?
Got it. So sometimes those questions can be really hard to answer. And I think this is where having the multidisciplinary team come in, because it's not just on the oncologist or the oncologic endocrinologist. I mean, this is something that when we're looking at end of life, we're also working with supportive care, your primary care, working with everyone as a team. Because I think one thing that makes that question particularly challenging is that's going to be different for every single person. So part of that is that person coming together with their team to come up with a plan that entails their wishes. I'm not sure if that helps, Christine, but looking into seeing if your facility has something like supportive care. I hate using the term palliative care because I think the minute we bring up palliative, people think, well, I'm not trying or doing anything anymore, and realizing that a lot of the times it's symptom management, and what it truly is supportive care.
Yeah, I think the primary issue, so it's not me, it's my husband, and he is trying to decide. He's at the point where he has asymptomatic disease, but has been progressing, and thyroglobulin is telling us that, and scans, that it's probably time to go to the next stage of treatment. And he's in his late 60s and trying to decide, wait a minute, like I have a pretty great life, like right now. What does the future hold for me? And when we went to see the doctor around possible other treatments, you know, his eyes just got really big. And when my husband said, like, will I have a hard time breathing? And he said, no. And he said, will I start to cough up blood? And he said, no. And I'm a nurse practitioner. And I'm like, this guy just does not want to answer the question. And I feel like that is so unfair. And even in other conversations with our regular endocrinologist, when there are difficult things in conversation, you know, she ends the meeting with like, oh, have a great day. And you think, okay, you just told me that I've got 3 more tumors and that they've grown by this much. I don't think I'm going to have a great day. And I think that there is it's such a lack of respect for the patient, for them not to be comfortable with the hard questions. And I guess that as endocrinologists, often you are dealing with people with pretty simple stuff that aren't going to die, but that's not true for everybody. And I feel like in our situation, we don't have a team that doesn't exist where we live. And so it's a very lonely thing. And even getting a second opinion, when he phoned a friend in Boston and spoke with someone at Mass General, and they said, well, you know, you're not going to die from this. I'm thinking, okay, well, how do you know that? So I guess I just find that it's the lack of transparency, the lack of respect for the really hard questions, that if as a patient we are asking those questions, we want the answers.
Oh, for sure. And it sounds like, you know, it wasn't the best experience and not the best communication. And, you know, I can't speak to anyone's particular case, but what I'm hearing overall from that is, you know, you might be seeing someone who isn't comfortable because they haven't had high volume advanced disease, okay? And frankly, may not know those answers. So we'll get to it in a little bit later in this talk, in particular about when I would consider seeing an endocrine oncologist or an oncologist as well that, you know, has experience with this and can better answer those questions. And a lot of the times it is more than kind of, it's actually going to that institution and getting a formal second opinion, having the case reviewed, et cetera. I mean, I think sometimes, especially in thyroid cancer, we often do a period of what we call active surveillance, which is when we know the disease is there, we know there may be some mild progression, but we watch. And again, having been on this on the other side as well, from a family perspective and other disease processes as well, that can be really hard to hear. And even if it is the right, in quotation marks, answers, sometimes it helps to hear that from more than one person. So we'll get to, I hope we get to the meat of your question in just a little bit, but please chime in again at the end if we don't end up covering it. Anyone else? Okay. So we went over in terms of, again, if your gut's telling you something's off, et cetera. So some other times that we would consider getting a second opinion specifically, okay? So anytime you're uncomfortable with the doctor, I'll be the first one to say, you know, we all have different personalities, right? My personality can be a great match for one person and an awful match for the next, right? That doesn't take away from you as a patient or myself as a physician. Sometimes it can just be a poor personality match as well. And, you know, being willing to say this doesn't work for me and trying to find someone else is definitely a place where you can advocate for yourself. If the treatment plan sounds off or not what you read, this is something Dr. Sosa and the team for the next set of thyroid cancer guidelines I know is really working on. She brought it up in her lecture here. Is, you know, we want the guidelines to actually be a place for patients to go to also be able to, you know, hold providers accountable in terms of, hey, I read this, what are your thoughts on this, et cetera. And they're working on having diagrams per specific thyroid cancer type that make it a little bit easier to understand and allow you to be your own advocate. Rare diseases, so looking at the ATC, the hereditary syndromes, et cetera. Or if what you're told as a treatment plan sounds specifically morbid. In other words, you know, like a total laryngectomy, pharyngectomy, et cetera, those things. Not saying that that isn't going to be the end answer, but that's a particular time where I would definitely recommend getting a second opinion, because obviously once you move forward with those things, they can't be undone. So again, going over one, as physicians, we particularly encourage them rare tumor types, such as our advanced or metastatic disease, our anaplastic thyroid cancer, medullary thyroid cancer, and any of the endocrine neoplasia syndromes. Another one that I've often seen come up is someone who's had multiple neck surgeries. And, you know, it's their 5th, 6th neck surgery and it's coming back. That's when I'd really be thinking, you know, maybe a fresh set of eyes would be a good idea, okay? Or if you've had, unlike surgery, just keep on getting radioactive iodine time after time. Again, another thought to maybe consider getting a second opinion. So just some caveats about second opinions. It's, you know, we all have the right as a patient to request a second opinion, but it does have to go through your health plan, okay? Sometimes a health plan may actually say that you have to have a second opinion before they'll grant a treatment. Travel is often required and can definitely be costly. And a health plan does not have to grant you a second opinion at the location of your choice, okay? Now, this is something that I take to heart as well as a physician, and it's just, you know, just because you ask for a second opinion does not mean that you do not like or trust your current doctor. It could be one of those situations where you want to go and see, is this the plan? Because it is a gray area where people may recommend different things, okay? It's okay to get a second opinion and still continue on with your original doctor. No doctor, whether you're the first opinion, second opinion, third opinion, should ever get their feelings hurt about you wanting another opinion, okay? The whole goal for all of us is that you're comfortable with the treatment plan, okay? They've done some literature, and of course, this is not specific to thyroid cancer, but in terms of second opinions and how often it can result in change. Not specific to thyroid cancer, this was just an overall study looking at the diagnosis can change 15% of the time, treatment 37% of the time, or both 11% of the time. And it could have a significant impact on each individual case. So I think it's interesting to show that literature supports getting a second opinion as well, okay? This can be a little bit hard of a question to be open about, but has anyone ever gotten a second opinion, and either regretted it or were very happy with the second opinion and want to share it? I know part of it you already.
I did. I went to, I live in Seattle, so we have the Fred Hutch Cancer Research Center, and that's where I went to first because I don't know, I have cancer. That's where I thought you should go. They told me when I made the appointment, it would be a 3-hour appointment. I'd have this whole care team of all of these people that you mentioned. That was not the case. 2.5 hours of that appointment was spent in the waiting room, waiting to go back into the office. I never met with any of those people but the doctor. And when she walked in, she came in, she shrugged her shoulders. She said, might be cancer, might not be cancer. And I'm like, well, the testing said it was cancer and the genetic testing said it was cancer. The appointment did not go good. So I kind of freaked out, didn't know what to do. So I asked around and got some opinions on another, like, who do I look for? Got some names, did some research, went to a completely different clinic. So happy that I went with him. His demeanor right off the bat was completely different. Like the first thing he said to me when he walked into the room was, "Hi, my name is Dr. So-and-so. I'm going to take care of you." It was way different. And he listened to my concerns because the first doctor only wanted to do half. I've read lots of times you do half and then you have to go later and do the second half. I'm like, I don't want 2 surgeries. So she was like, no, we're not gonna do that. The second doctor was like, yeah, you've been battling your thyroid for 13 years. I think you'll feel better if it's all taken out. And I don't know. I was happy with my second choice. I kind of felt bad the first when I like, no, don't want to go with her, but I'm glad I went with my doctor.
Yeah, I'm glad you listened to your gut, had a good experience. Hi, Bobby. If you want to go ahead and unmute and ask your question.
Well, I just had the perspective from seeking a second opinion. I had a care team, which I found out it started with my PCP and that referral to ENT, and I had surgery, and then they referred me to endocrinology, and that all started in 2021. And then I had to have a second surgery by 2022. And then it was back again. And I thought, oh, I need to seek a second opinion. So I sought out a second opinion, and they asked me that question, did they do molecular markings? And I'm like, what does that mean? Sometimes I think it's you don't know the right questions to ask. And so then when I went back and asked them on those pathologies, did you do molecular markings? They're like, oh yeah, it says it's cancer. We're good. Like, we just have to treat it again. You just have to do surgery. And I was like, yeah, I don't think I'm going to go with this team. And then I went with a whole new team, and they did I had a third surgery. So I've had 3 surgeries now and 2 radioactive iodine treatments, and I don't respond to those radioactive iodine treatments. And now the molecular testing says RET positive. So, so I think it's very important sometimes to get that second opinion, but it's hard to know what questions to ask. So I think I've learned a lot coming to this, this conference, because I've realized that there's so many more different molecular markings and things like that I can go back and ask appropriate questions now to my team.
I think that's why these conferences are great, and also sharing with each other, being aware of when the major guidelines are coming out. The American Thyroid Association has a lot of different things put together as well, like clinical thyroidology, where physicians actually review articles and say how it may change their practice. That is kind of put together for the physician scientist community. There's also a clinical thyroidology for the lay public. Now, I will say most of my patients would probably maybe not find those the best fit and would actually find the other ones a little bit better of a fit. So look at your resources, use each other. Yeah.
It wasn't a question, it was answering for the second opinion. In my experience, I had a surgery scheduled for a Tuesday. They told me on the Thursday, so I just had the weekend to prepare, and I had to get my consultation with the endocrinologist on that Monday. It was my I have a lot of family who works in healthcare, so I feel very comfortable in doctors' offices. Before going in, the medical assistant told me, make sure you ask your questions. Sometimes you have to ask her 3 times. She doesn't answer them. Just that prep made me feel weird. I had a list of 7 questions. They didn't answer any of them. She made myself and my mother cry, like making us so nervous, saying, oh, it doesn't look good. We're going to have to take out the whole thing. I said, that's not what I discussed with my surgeon. He said, we're only going to do half. And I don't want to be on the medicine for the rest of my life because I want to do half to see if I can function without it. And I complained the next day when I was going into surgery. I was freaking out and said, I don't want to wake up with not talking about what we discussed. And he walked me through and said, don't worry, here's the paperwork. We discussed that we're only going to do your left. When you feel better, we can refer you to somebody else who's in the clinic. And I reported it to the office and said I had a really negative experience. I couldn't talk. So I had my mom call the office and said, here's our experience. And, she said such and such things, didn't make us feel comfortable, 0 bedside manner. And I ultimately got a referral to a different doctor in the same network who's really great. But she doesn't take new patients. So I'm still looking for a new one for long term, but I was able to at least get the immediate care and do my tests. But yeah, just not being afraid to mention it and report. And then later on, a few months later, I got a letter saying she no longer works at the practice.
I love having people talk up because you can see 2 people who had completely different wishes, right? Like you were very, you really only wanted half out, right? And we just talked to someone up here who's like the exact opposite. I wanted all of it out, right? So you have to be able to express your wishes because every person is different. And, as the providers, we don't know because everyone has different reasons for why they want one thing or another. So knowing what you want and trying to advocate for it is important. I also love the idea of writing down questions before you go in because I don't know what it is with doctors' offices, having been very familiar with them, but I think you walk in and you forget everything, and then you walk out and you also forget everything. So writing things down ahead of time is really, really, really important, okay?
I've got a question online, and then I've got someone that wants to speak.
Yeah, of course.
Elaine asks, I cannot seem to find a solution for the calcium calcitrol therapy. 50 milligrams a day, 500 milligrams every 4 hours, and 150 in multivitamin calcitrol 0.75 a day. My stomach has hurt since then. I have severe indigestion with acid in my throat, feels like a ball. It hurts to talk. I gurgle with what feels like phlegm. When I exercise or walk, it's worse. I cannot work out or bend over without exacerbating the acid/vomit in my throat. Doctors cannot find a solution. Where can I go to get help? And second opinion, Kaiser patient, I will pay out of pocket if necessary.
So again, that's one where I would say talk with your resources, okay? Sounds like she has a bad case of hypoparathyroidism. Unfortunately, some of our options have been limited, but there are some options that I've seen use. So what I would say is talk with other ThyCa members, see if someone in the same situation has gotten support. Specifically look up people who have a very specific interest in hypoparathyroidism. Oftentimes that can also be bone specialist as well in the endocrine world rather than your typical thyroid cancer specialist.
And Shannon, you may unmute and ask your question or make your statement.
Hi. So I've been a personal injury paralegal for a long time. And so my approach when I got diagnosed in approaching a second opinion was maybe a little overboard, but I feel like the average person doesn't really know this is an option, but you can look up the doctor that you're speaking with, consulting with on your state's medical board website and see if they've had any like complaints and kind of thing. And you can do that with nurses as well. And then, so I ended up doing that. And then also like just looking at a lot of Google reviews and other patients' like experiences. Because when I originally got diagnosed, I was diagnosed by a regular ENT that was looking for something else. And I asked him the question, like, how many of these types of surgeries have you done? And his was like, this practice does a lot of them, which didn't really answer my question. And so I ended up going and seeking a second opinion with a endocrine surgeon who was kind of young. So she didn't really have any Google reviews, but when I asked her the same question, she said she had done over 300 of the type of surgeries in the last year. And so she was actually at a cancer center, which I found to be really helpful because not only do I have her, but like she constantly consults with my endocrinologist. And then when I had radioactive iodine, she consulted with a nuclear radiologist and all that stuff to like kind of come up with a plan for my care. Like they've gone to tumor board for me, and like I had an issue where my thyroid globulin kept rising and nobody knew why. But then when they were talking to the radiologist on my last PET CT scan, they were able to find that the reason for my thyroid globulin levels were actually behind my trachea, so they couldn't see it in ultrasound or on my whole body scan. So I think it's important, one, if you haven't considered it, to try to see if there are any cancer centers with endocrine surgeons. And also my specific cancer center also provided counseling for cancer patients, which was free. And I think that was really helpful as well.
You're pointing out exactly how a multidisciplinary approach and being at a center with resources can really, really be helpful. I think you're also pointing out sometimes people go to centers and there's resources, but we don't take advantage of them, okay? So knowing what resources you have available and using them, okay? Thank you for sharing that.
I have a question from an anonymous member attendee. My lifespan is projected at 5 years based on stage 3 multifocal metastatic greater than 45, and then in parentheses 59, 4-centimeter lymph node tumors. 2 years into the 5 years, how can I get support to go on disability so I'm not grappling with thyroid symptoms and work while I live out my last 3 years?
So, you know, it's hard to know or be able to comment kind of without specific information regarding that, but I'd really recommend that they touch base with their primary care physician as well as their cancer team.
Can I add to that really quickly?
Yeah, go ahead.
My therapist was really helpful in that process as well. I just came back from a 6-month leave. So whoever asked that question, if you have a mental psychotherapist or anything, make sure you talk with them as well, because mine was the one who actually put me on a leave. It wasn't my actual physical doctors. And if it wasn't for her, I probably wouldn't be here today. So.
See, and this is why things like ThyCa and sharing your experiences are so important, right? So thank you. I mean, that's another great resource to be able to look at. And, you know, another reason why people, when you have a thyroid cancer diagnosis, we have to make sure we're addressing everything, right? Both our mental well-being, other disease processes or chronic conditions we may have. We really have to make sure we're taking care of everything.
When one is looking for a second opinion for a doctor, would you recommend looking for someone who's associated with like a university where they have research, or, you know, let's say there's an establishment, like I'm also from Seattle, we have University of Washington that has a lot of stuff, but then there's also Overlake and then there's Swedish. So how do you decide which ones? And then Aubrey went to Hutch, but had a negative experience. So how do you determine? Because I just find myself looking on health grades, looking at people's reviews, looking at those types of things.
And I'm always hesitant to use those, like Google reviews, health reviews, because, you know, they may or may not reflect what's going to be your own individual experience with that doctor, right? So the things I would definitely look for are a multidisciplinary team, right? If people have those, they advertise that they have a multidisciplinary team in tumor board, et cetera, right? That's not something we hide. Those take a lot of work to put together and continue to orchestrate, okay? Looking for surgeons that have a particular interest in thyroid, et cetera. Because realize people who are passionate about one disease process love to work together, right? So they come together. So I would look for the high volume surgeons, multidisciplinary team, endocrinologists that have a specific interest in thyroid cancer, if that is your main concern, and look for those expertise. Oftentimes, those will be at academic centers because it does take a lot of infrastructure to put that together. Okay, so moving on to our last topic is when to see an oncologist, okay? Yeah, go ahead. Got it. So one of our Zoom attendees is asking, how do you find a high volume surgeon? This can be a little tricky. And what I would say, if you're unsure, this is when I would recommend touching base with an endocrinologist beforehand, right? It can be in terms of regional areas, et cetera. It's different for each person. And you want someone who's going to be working with your endocrinologist long term. So I'd recommend touching base with your endocrinologist or establishing with an endocrinologist if that hasn't happened. Okay, so in terms of when to see an oncologist, so kind of going over the differences, and endocrinologists are doctors basically who take care of glands, hormone issues, et cetera. As endocrinologists, we're all trained in pituitary, adrenal disease, diabetes, et cetera, okay? That is a fellowship after you do a general medicine residency, okay? Now, I will say the vast majority of thyroid cancer patients are treated by endocrinologists, okay? Specifically in low risk differentiated thyroid cancer, et cetera, okay? And many patients who have a low rate of recurrence may not have to see an oncologist at any point in their journey, okay? When I would look more so for a medical oncologist or oncologic endocrinologist, medical oncologists are those who did the internal medicine residency and then went on to do a oncology hematology fellowship. So they treat all cancers, breast, prostate, all of them. They're trained in that. May or may not have significant exposure to thyroid cancer, since traditionally thyroid cancer has been treated by endocrinologists. And a relatively newer and emerging field is oncologic endocrinology, okay? For instance, I'm currently doing a fellowship year in it, and I'm MD Anderson's 11th fellow, okay? So it's been around for about a decade. And is a growing field. It's something I'm really passionate about. I think as chemotherapy no longer means, the chemotherapy people used to think of port, losing hair, et cetera, that we're going to see more and more people kind of going into this world of oncology in their individual areas of expertise. We've already seen it in neuro-oncology, where that happens with neurology, and gastroenterology as well. We've seen similar things. So I'm really excited that we're seeing this in endocrinology as well, and hoping more and more people want to get trained in it. Because I know, speaking with patients this weekend, it seems like there's a real desire to have someone who can do both, okay? So I'm hoping that will be more of the case with time. So these are generally physicians who treat thyroid cancer. You will see different meaning, different topic, but there are oncological endocrinologists who specifically treat things like adrenal corticocarcinoma and malignant pheochromocytomas, et cetera, other endocrine glands that can also have malignancy. In terms of when I would recommend seeing this is when you have more advanced disease. In other words, disease that's going into other areas of the body or into your trachea or esophagus, et cetera, okay? Or when you're at the point, I think our patient who kind of brought up earlier that they've been told, that they may need to take next steps, but it didn't really seem that the person they were talking with knew what those next steps may be. So that's when I would recommend consideration of seeing a medical oncologist who has experience with thyroid cancer or an oncologic endocrinologist. And the reason there's a slide saying discuss care team 10 times is because this is going to be totally different depending on where you're at. There's different models at all the major cancer centers, et cetera. So it really is going to depend on where you're at and talking with your endocrinologist, et cetera, okay? Sorry. So other things to bring up is, again, when systemics are coming up, if you have different metastases that are growing slowly over time, et cetera, that would be when I'm bringing up with my endocrinologist, hey, are you comfortable prescribing systemic therapy? If not, do you think there's someone that I could talk to, okay? Because what we don't want is waiting until we're having disease really, really advancing and then going to that person, because it does take time for molecular testing to happen and all of those things, okay? So ideally, it's done a little bit earlier in the process. If your endocrinologist brings up that you should see an oncologist or anything like that, and the last one is, again, if you're having multiple surgeries or multiple iodine. I think we have a question in the audience.
I love this.
I have some.
But I have two questions.
Yeah.
What would you consider a systemic therapy?
So when I say systemic therapy, it's an oral chemotherapy.
So kinase inhibitors?
Yes,
Okay.
kinase inhibitor, RET inhibitor, TRK inhibitor, any of them. You know, any of the medications that are meant to treat disease anywhere in the body, right?
Mhm.
Whereas I consider more of like a localized therapy, external beam radiation to a lung lesion, to a bone lesion. So something that's meant to treat the disease that's left in the body.
And thank you. My second question is around when you talked about if a patient is experiencing metastases and the endocrinologist is not, you know, they're like, it has nothing to do with me, which I've actually heard. How do you advocate for yourself? Because it's me, right?
Mhm.
I had thyroid cancer 2015. I've had about 10 metastases, all benign, but they keep coming back and they're growing everywhere in my body. How do I advocate for someone to actually pay attention? Because it can't just be coincidental at this point.
So that's when I say get a second opinion at an institution that sees recurrent thyroid cancer. And I will say the comfort level of each endocrinologist will be very different. Like even before doing this oncological fellowship, I had the luxury of training at MD Anderson before, so felt comfortable with this, but not every person will, okay? So it's having an honest conversation with the endocrinologist. Are you comfortable? Is this something you see often?
We have a question online from Elaine.
Mhm.
I am a Kaiser patient. They do not have the support teams as described in this conference. Are there these types of medical support in the San Jose, California area? Please help.
So I will say this is when I bring up that sometimes insurance can be quite a beast. And that is you advocating for yourself with your insurance and seeing what you can to get outside of that system. Being from Texas, I'm not as familiar with the Kaiser system, but it's a matter of documenting and proving that those resources are not available within the system you're in itself.
Bear with me, my vocal cord was paralyzed. Building off of that, my insurance company has a patient advocate nurse. They might have one as well. And they can help set up care teams and get you what you need. They can help you with financial aid, helping you with different scholarships to help get you what you need and you can't afford. So I would say call your insurance company and ask them what support systems they have.
And I think being honest about it and open about it, you know, I think it's just a reality that healthcare is very, very expensive. And to say that it's too much or I can't do this is nothing to be ashamed of at all. So again, being open and willing to advocate for yourself.
California.
Perfect. So Stanford, there's also City of Hope in California as well, kind of looking at those things where people may have more individual subspecialization. So it sounds like she may have gone to general oncology, because typically general oncology is head and neck, which does a lot with like squamous cell carcinoma, et cetera. And this is where I would touch base with her endocrinologist and see if they can further advocate for exceptions outside of the system. Yeah, and we were kind of at the end in terms of when, as far as if anyone had an experience, I'm glad everyone was able to participate, but if anyone had any last minute things to share as far as, you know, that transition going from endocrine to oncology, or, you know, having an oncologic endocrinologist, they're not as many throughout, but yeah, I mean, definitely talk with each other and share those. And